recommended a blood panel that included a D-dimer 9 months ago for anyone who came in with fatigue, tiredness, chest pain. They would say none. Now, if you're not doing a D-dimer and you're not looking at clotting history, you've possibly missed something. So it's different now.
Hello, Dino. Hello, everyone.
Hi, Steve. Nice to have you there. Hi, Dr.
Thank you so much.
Dr. Polakov, Gail.
Hi, Dr. Sofianos.
Dr. Sad, Dr. Sofianos. Thank you, Dr. Udelman. Thank you all for being here. Anita Beer, I see you are there. Thanks all for being there. Got about 3 minutes before we start.
Well, maybe I could ask you as the host today, is there anything particularly you'd like to hear from me about? Any particular questions?
No, not really. I'll leave it to you. I think if you have any questions at the end, I mean, our colleagues will be keen to ask. But I mean, I've got nothing specific really to ask you.
Okay. You know, for 2 minutes, it's enough time to prepare. Yeah.
Brad.
I'm sure you are well prepared, so don't stress.
I try
Dr. Brad, always well prepared.
Is your rain finished up there now? Is it nice, gentle autumn weather?
Today it is.
Yeah, it is actually quite nice today.
And you, Brad, in Cape Town?
It's last 2 mornings it started to get a little bit crisp. Last weekend was very hot. It was our hottest weekend of the year. Not this one that's passed, the one just before that. Now it's getting cooler, so it's partly cloudy, but it's almost getting to be sweatshirt weather, and autumn's on its way. It's no suffering here.
It is exactly 7:30. Good morning, everybody. Welcome to our CME meeting. I would like to start by inviting someone from Genoa Underwriting Managers and Jeanette de Villiers from MC de Villiers, who are sponsoring our meeting, to introduce themselves. And I will then invite Dr. Brad Beira to talk about medication errors. Thank you very much. Mr. Endowment.
Thank you, Dr. Sofianos, and welcome to all of the practitioners who are joining us this morning. My name is Michael John Demant. I'm a director at Genoa Underwriting Managers. We are a liability-focused insurance company. What that means in general is that we focus on professional indemnity for specific professions. One of them, of course, which is why I'm in the room today, being medical practitioners. Genoa has got a long history in the professional indemnity space, and that is what we do every day of our life, 24/7. So if you look in the news currently, there are a large number of very large professional indemnity matters that Genoa has been involved in. The likes of companies such as Comair, Group 5, Edcon, South African Airways, Stack, name those matters, we do it. Our medical malpractice product, more specifically, is also fantastic. in that we've just recently broken 1,400 medical practitioners. That was a number that we've been pushing hard to secure. Yeah, it's via MC de Villiers. Sorry, someone's speaker seems to be off. I don't know if you can.
And a adorable little cameo during the couple's 90-minute interview I told with Oprah Winfrey. They love them, and they also love what it gives to us.
Anyway, so via MC de Villiers, Jeanette, who's going to be speaking to us shortly, you guys can find out more about the product. So without further ado, I'm sure everyone's looking forward to listening to Brad's talk. So I'll hand over to Jeanette and yeah, enjoy the presentation.
Thank you very much. Please, I'm trying to mute the people who are not talking. Please mute yourselves because there's a lot of background noise. I'm trying to, but I cannot mute everybody. Please mute if you are not talking. This is the Villiers.
Thank you. I'll be with you in 1 second. I just want to share my screen. Share screen. Sorry, just give me 1 second.
No problem.
Okay, now for some reason I'm not able to share my screen, so I'm not going to be sharing it because I don't want to lose the opportunity of speaking to you. It's a great pleasure of joining you this morning. Thank you very much for the opportunity of all joining the Medical Areas talk this morning. I'd just like to introduce you, for those that do not know me, my name is Jeanette de Villiers. I'm from MC de Villiers Brokers. My passion and core focus is medical malpractice, and I focus on offering my professionals absolute peace of mind. I know the complexity that the doctors face each and every day during these very challenging times, and my role as an intermediary is to look after the professionals and take away any unnecessary burdens from an administration, stress and risks associated to the medical malpractice cover that they currently have in place. We also review their cover on an annualized basis to ensure that they have market-related medical malpractice at a competitive premium. My core focus is to ensure that you have no distractions in your practice and that you're able to look after your patients effectively. I am the go-between the insurer and your practice to ensure that you get timely feedback and exceptional service at all times. I support you with all the relevant documentation that's required in your practice, from informed consents to risk mitigation documents to maintaining minimum standards of healthcare records and ongoing trends and information on an ongoing basis. We believe in building partners with our professionals, and we want to be an advisor of choice in the industry. And I thank you very much for the opportunity and look forward to meeting you after the event. I will be issuing your CPD certificates. And over to Dr. Brad Byra. I hope you enjoy the talk. Thank you very much.
Thank you very much. Dr. Byra.
Thank you. Good morning to everyone. It's such a pleasure to be back with you. I know that I spoke with you last year, and I'm always staggered at how fast the time goes between days and events. And I think I remember being at school where it took so long for a year to finish, and now I'm past school and it feels like things are just flying by. So we're going into our second year of these kind of CME conversations where we're not face-to-face. We're all in our own spaces, but we're all largely together. I wanted to share with you today the medications errors presentation, and we'll go through this and have some conversation. Stop me anytime by putting a note on the chat to ask a question. And the goal here is not to tell you what you're doing right or wrong, but to share with you some of the best practices in limiting medication errors that we're seeing worldwide. I do this as a part of a lecture series that I do across SADC on medication errors. I'm going to reference a fair amount of what's going on from the World Health Organization best medicines practices and just create some context. We can answer one or two specific questions and maybe use an example or two that are happening in our related therapeutic worlds right now. But really, health systems are designed to benefit patients, but they can also cause harm. Sometimes it's intended harm, sometimes it's an unintended harm. And it's that complex combination of the processes, technologies, and human interactions that create our healthcare system. Now, in that world, every time we bring in multiple processes and multiple technologies, we amplify or increase the amount of risk to making an error. When we add ourselves to that, the risk of patient error increases exponentially, and sometimes even more than that. So initiatives like the Medication Safety and Polypharmacy Strategy that the World Health Organization has put forward addresses to a large extent this kind of risk. Now, those of you that work as you do on the wards, you'll know that you're using an Omnicell, or you're using some kind of electronic dispensing or storage and dispensing unit. You all know about those old look-alike, feel-alike issues where saline and insulin got mixed up and other kind of risks. So managing the processes is probably one of the biggest challenges we have. Now, a medication error is not only an adverse error, but it's also a sentient event. It's one of those that you should be looking at that should never, ever happen. And yet, it's the 14th leading cause of morbidity and mortality worldwide, which means tuberculosis, malaria, and adverse events kills roughly the same amount of people in a year. That's staggering to know. Now, one of the things there is, how can we prevent harm? Specifically, as an introduction, avoidable harm to patients during our care. And as a consequence of that, the global patient safety challenges created through the WHO a strategy called Medication Without Harm. Some of what we're going to do today, you can reference. You'll see the references on all the comments that I make are on the side there. So it's already 2 years ago, but from medication safety in high-risk situations, as part of the Medications Without Harm strategy of WHO, we're going to go through the journey together. And it begins with a wheel where the center of that is around the safety of people. So it's not only the safety of the patient, it's the safety of us as a practitioner. Because when we talk about the P's, we talk about the practitioner being us, we talk about the patient being who we're responding to, and their immediate family. And ultimately, we're talking about people. So in the middle of this is people. Then on the wheel, we look at the 4 wheel segments, or the 4 pillars of what creates safe medication practices. The first piece of that is us as healthcare professionals. Now, here we look at, well, do we have the right education and training? And usually we do. We're pretty good with education and training by and large. We're pretty good with what we're doing. Are we as good with teamwork and communication? And probably we're not as good as we might be when it comes to teamwork. We're not bad, but we're not excellent. And if you like to read books on this, I'll give you a list of many and we can share them through, but I'm going to reference, as I often do, Atul Gawande. Atul Gawande wrote a book called The Checklist Manifesto. It was his first book on his reflections working with the WHO on continuous patient improvement and continuous quality in healthcare. What he came out with is, he said, do we have a checklist or a standard operating procedure that we tick off the steps one after the other? And it shouldn't be more than 4 or 5 steps, but do we have those steps in place? And if we don't, what step are we often missing out? And he uses inserting a central line and removing the guideline as one example, and the difference that full drapery versus half drapery makes. But he wrote a second book called Better, where he continued to expound the joys of using a checklist and how it improves clinical outcomes, specifically in surgery and notably in medication errors. But then he wrote a third book called Complications. And in Complications, he said, notwithstanding the first piece of the wheel, the education and training, notwithstanding our need to communicate and our need for teamwork, we do it particularly poorly. We don't collaborate well intercollegially. We don't collaborate well interprofessionally. And that's a big area for us to address, because that addresses the third piece, which is capability at point of care. When you're doing handovers, whether they ward handovers with the nursing teams at change of shift, or we're doing patient care or transitions of care handovers, are we as thorough as we could be? And then the fourth piece of us as professionals is, are we reporting our incidents? And are we learning from those incidents? So things like CME is really good. M&M issues, the morbidity mortality meetings? I'm sure you have them on a regular basis. And are you doing root cause analysis meetings? So I used to be a hospital risk manager at a specialty orthopedic hospital. The things that we learned is, are you doing root cause analysis on outcomes? How often when you have an adverse outcome, you sit down as an interprofessional team and say, right, we treated Brad. Brad came in for X, decompensated at Y, required additional days worth of care because of Z. Now, what were the root causes? Were we recording properly? Were we communicating properly? Were we having interdisciplinary team meetings? Were 2 or 3 clinicians prescribing at the same time, unaware of each other? Because we know that polypharmacy is an issue. So that's our wheel when we start looking at ourselves as healthcare professionals. We're going to go through the presentation, but this is just the introduction. Then we start looking at the medicines and the right product at the right point of care. So when we talk about the 5 rights of medication delivery, or the 5 rights of safe medication management, think in your mind now, do you know what those 5 rights are? And park that, maybe write them down if you feel like it and challenge yourself. We're going to come to it later. But there's the right product at point of care. And then there's logistics, storage, and disposal. So now we talk about rolling out our vaccination strategies. And the chap says to me, I say, how hard can it be? We just go out there and we vaccinate. He says, not only that, what the guys are doing is they're taking the vials with 5 doses, but there's a little bit left over, and then they're combining them together, and then they've got a 6th dose. And I'm starting to think like, are we now moving out of safe medical practice or safe medicine practice into slightly different areas? And then he says, well, how hard can it be? You know, let's just get contained vehicles and a couple of fridges, and then we can cold store manage the vaccine. So, well, you all know that vaccine cold storage and the cold chain management is particularly difficult. How you cycle out the medicines, how you're managing end-of-life medicines are big deals. Also, naming, labeling, and packaging are big deals, and product quality are big deals. So when we look at medication, we're not only looking at what we as practitioners do, but we've got to recognize that the medicine itself has inherent risks. I'm going to apologize now, possibly for later, because I might have to stop for an unscheduled CAT scan, because the cats have a habit of jumping up, peering into my camera, and then dropping down again. So if it happens, I'm sorry, it's one of our challenges. Also recognize, when we look at the systems and practices of medicines, how are we governing our medication practices? How are we managing our prescribing, preparing, and dispensing? In the hospital, how often are you having a conversation with the nurses and with the pharmacist and the pharmacy manager to start talking about how you're managing medication throughout the journey? And then how are you doing your administration and patient monitoring? How many of you pick up your phone the day after you prescribe a new medicine and write a text to the person or a WhatsApp to the person, or call them and say, we changed your dose yesterday, how are you doing? And those are the easy ones, because then we get to the 4th wheel. The first 3 wheels we can largely control to some greater or lesser extent. The 4th wheel is the patient and public behavior, their reporting, their engagement, and their awareness and medication literacy. Now, I say this because since we spoke last, one of the big lessons that came through for me is, those of you who've got nothing else to do, you can have a read of the Health Professions Council Ethical Guidelines. Booklet 3 of the Ethical Guidelines is around the patient's responsibilities and the patient contract, and that includes the Patient National Rights Charter. That includes what the patient's responsibilities in their own care is to do, what their accountabilities to share with us is in terms of their feedback, in terms of their exposure, in terms of their levels of comfort. So often patients don't know what's expected of them. They go away and they say, I took this medicine, I'm not really feeling great, but I'm not feeling bad. But they don't call you up and they say, Doc, look, you gave me this preparation and I'm not doing so well as a consequence of that. So bear in mind that these are risks and issues for us to do. So when we start looking at pharmacovigilance, my question to you is, what kind of pharmacovigilance strategy do you have for your patients? Because ultimately we want to improve patient care and safety. By extension, public health and safety, especially now as we talk about COVID and COVID-related care, When we start addressing these 2 points, and we start looking at detecting problems relating to medicines and communicating findings, the debate about something like ivermectin becomes quite a big debate. And we might touch on it later if it is or isn't appropriate. But it also talks about whether we're using an on-label or off-label preparation in the manner of which it was designed and the manner in which it was registered. This all helps us contribute to whether we're doing benefit and harm. And if I were to ask you from your practice, how many patients complained of a medication adverse effect a day to 2 days to 5 days after you changed their medicines? Did you give a diuretic that might be diabeticogenic without realizing that it's affecting them? And they're not telling you because they're seeing somebody else for their diabetes and they're seeing you for their hypertension. We see that those interactions play a big role. And then this should encourage, but it often sometimes doesn't, the safe, rational, and more effective use of medicines. And it helps us in conversations like this, looking at education and training. So pharmacovigilance is important in the big scheme, but are you pharmacovigilant in your practice? So I'm not telling you anything here that you don't already know. This might be in a slightly different order, but you should be nodding and saying, yeah, this is pretty much how I live. So in terms of medication use, look at Informed Consent, Booklet 4, Confidentiality, Disclosure and Record Keeping, Booklet 9. In your contemporaneous notes, and I smile as I say contemporaneous notes because I'm sure you're keeping thorough notes. You've got notes on your rationale for prescribing, you've got notes on the dosage, and you've got notes on the other medicines where you've created some kind of link of potential side effects and interrelated pharmacological impact. So you've got your patient information. You've also got your drug information that should be recorded in your records. You'll see there that it's linked in, sorry about that, it's linked into Booklet 5. Then my question to you is, what kind of SBAR or adequate communication strategy have you got on the medication journey that you're doing between yourself and where you're scripting it out to the pharmacy and the patient and potentially their family? So there, what is the situation? What is the background? What is my assessment? A little bit like a SOAP note. And then what are my recommendations? Bearing in mind, and less importantly for us, the drug packaging, labeling, and information, and the drug device acquisition. But certainly you would want to know about your environmental factors. And I refer you there to booklets 1 and 2, your role as a practitioner and your role in providing ethical healthcare in terms of the Health Professions Council. Then there's the question of staff education. If you have front office staff who field your calls, what kind of messaging are they giving to the patient? If I call in as a patient and I say, Doc, you know, and I talk to your nurse or your front office staff member, and I say, I want to chat to the doctor because I saw him yesterday and I'm not feeling so good. Does your staff have a training manual that says, oh, right, I see you were here yesterday. Are you calling about your treatment? Are you calling about your medicines? And if you don't mention medicines, they may say, oh, it's fine, please have the doctor call me back. So how you educate your patient and how you educate your staff impacts strongly on your quality process of how you manage your medicine. I asked you earlier about the 5 rights, and I asked you whether you knew what the 5 rights were. We spoke about that on the wheel slide. And so let me ask it this way. Do you have a medication administration record where you have a note, not only in each patient's file, but of that week of the medicine that you've prescribed, in which way? Did you get the right medicine, number 1, to the right patient, with the right dose, in the right route, at the right time? Those are what they call, and WHO positions this as the 5 rights of medication administration. Now, this might not directly affect you because you might not administer the medicines. But if you're in a chain of care and your patient is in the ward, is the right patient getting the right medicine? And from a medico-legal position, we so often hear the stories, and some of them are near misses, and some of them there was a mild reaction, and some of them there was an anaphylactic reaction, and some of them there was a catastrophic reaction. The right patient got the wrong medicine. or the wrong patient got the wrong medicine, and the right patient got the wrong dosage of the medicine. So ask yourself this again: do you have your 5 rights in place? Are you keeping your medication administration record? And if not, why not? Is it too hard? Are you too busy? Are you haven't thought about it before? Are you following up with your patients in the right way? Because we have challenges, and there are many challenges when it comes to managing medicine and medication delivery. There's the issues of substandard, counterfeit, and donated medicines. So one of the things that we have at the moment, and I'm going to use ivermectin as an example because it's all over our practices right now, is you're getting in a medicine that is potentially or not potentially being used on or off label. And it's either coming in one of 3 ways. It's either coming in as an illegal import, or it's coming in as part of a complex preparation that includes other pharmacological preparations, or it's coming in as part of a legal purchase. And then it's either coming in as a fluid or it's coming in pill form. Now, there's no control right now that's standardized, and no formulary dosage that's standardized, and no mechanism that's standardized to protect us from substandard and counterfeit medicines. We also don't know the interactivity with the other medication preparations. Those of you that get medical brief, there was a fairly insightful comment around the challenges. And what was insightful about it was that it addressed and speaks to many of these things. It spoke to the informal distribution channel. It raises the issues of interactivity with other medicines. It raises the issue of a potential counterfeit and substandard medicines. But then it also asks the 2, which are the blue comments there, the correct versus the incorrect use of the medicine and the risk of polypharmacy. So outside of that particular preparation, inside of our practices, our 2 biggest risks are polypharmacy and the incorrect use of medicines. So again, I'll ask you this question: how many patients that you have 4 or more medicines that are prescribed for them at any point in time? So conventionally, polypharmacy has been perceived as an overuse of medicines. Maybe it's more appropriate to talk about it in the use of the appropriateness of multiple preparations at the same time, because there are often times where concurrent use of multiple medicines is not only necessary, but also beneficial. And I put there the question for you to ask yourselves as part of the reflection, because this is not a clinical talk, this is an ethics talk. The question is, to what extent should we be involved in other professionals? And should we involve other professionals in the patient's care? How often that you have a patient where there are 2 or 3 prescribing colleagues, that you call up the colleague and say, I'm seeing Brad, I want to prescribe X, I notice that you've prescribed Y and Z. Is there a rationale for the choice of the medicines that you're using that I need to be aware of as I add another cocktail into the mix? So if you worry about metabolic side effects, should you call up the practitioner? And I use the example of blood pressure and cholesterol because recently there was a case, and recently 2017, so that's very contemporary, where the diabetogenic properties of the diuretic created a diabetic crisis. But because they were being managed by different practitioners, they were managed in different ways. And one didn't know what the other one was doing. Both dosages would change concurrently. And you ended up in a polypharmacy style storm that was very difficult to clinically manage the patient. The question that was then raised was, well, who's accountable for this? Who is the primary care practitioner? Principally in caring for a patient with multiple comorbidities. So the second piece, and you can read a very sobering article called Preventing Medication Errors, where these kind of things happen. And you can see that by giving the wrong medicine at the wrong time, patients die. And this happens frequently. Now, my question for you is, how often are you getting a medication error that's leading to a side effect? Now, we joke about this, and you'll see some slides later on, but an issue that was raised yesterday on a patient with limited capacity was the nurses couldn't read the writing on the practitioner's script. And so the dosage was wrong, and the timing of the dosages were wrong. So again, a question for you is, how legible are you in what you write with what you write? So if we move on a little bit from that now, we start talking about the incorrect use of medicine. And here we're looking at too many medicines per patient. We've spoken about that. That's the polypharmacy. Then it's the inappropriate use of antimicrobials, often in inadequate dosage and frequently for non-bacterial infections. Now, I'm not saying you do that, but I'm saying this is something that comes out fairly frequently. The overuse of injections when we can use oral formulation, failure to prescribe in accordance with clinical guidelines. Again, I ask you the question, in your area of specialty, are you recording your prescribing habits against your clinical guidelines? You either are or you aren't. And if you were challenged on it, could you justify and motivate why you're using the medication you're using in the manner that you're using it? Now, the next one of inappropriate self-medication. This is often a patient behavior that's enabled by us, because we'll either give a sample, or we'll make a recommendation, or we'll script out a medicine. We don't follow up to see if those medicines are finished. And what people do is they hoard those medicines. You find it with pain medicines. I have somebody who comes in and they say, oh, you know, I had this really bad headache, but it was fine because I used some of those Cerebrex. Well, how many did you take? And where did you get them? And they say, oh, I had them left over from my last procedure. Well, how long did you have them? Where were you storing them? No, they were in the cupboard in the bathroom. That's where the shower is, and it gets kind of hot in there. But they've had them for 18 months because they had the procedure 2 years ago. So you don't know necessarily what that patient is taking. So you ask them the question, what medication are you on? They don't tell you about their prescription-only medicines that they're taking on an ad hoc basis. Or they say, well, I took 2 or 3 doses of the antibiotic you prescribed, and I actually felt quite good. So I didn't finish the course. And then I felt bad again. And I remembered that I had the antibiotics that were left over. So I started taking those again. Now, I can't see if any of you are nodding, but I would be surprised if you weren't, because we don't always educate our patients into what they should be doing with their medicines. How many of you ask the patient to bring unused medicines back? And if you don't, maybe that is one of those safe medication practices that we should be thinking about. Then when I started back in practice, and I realized I haven't really been in practice that long. It's my 26th year now. So I'm still kind of getting into it and figuring it out. But there were only 1 or 2 health stores where you could buy homeopathic medicines or natural derivatives or naturopathic preparations. Herbal medicines were largely inaccessible unless you were growing your own St. John's wort in the garden. And now we start to see that there are significant amounts of therapeutically active herbal preparations that you can buy over the counter. Often patients don't regard those as medicines. So you say to them, well, what medication are you on? And those of you that are frequently doing surgery will know that if you should be asking the patients if they're taking arnica or Traumiel, because we found a couple of years back that patients were going and they were buying large amounts of arnica and they were ingesting it, and they were bleeding more than we would have expected them to bleed. And the reason for that is because the Traumiel contained large doses of arnica, and the arnica promoted bleeding, and that led to these kind of situations. So are you asking your patients in a thorough enough way what medications they're taking, and then what herbal medicines and over-the-counter homeopathic preparations they're taking? And I'm often stunned when I ask people, and you say to them, so how are you doing, and how are you feeling? And the person I spoke to yesterday, we went through a whole history, and we're talking about their adrenaline and cortisone levels, and we were talking about some medicines they were taking. And I was saying, well, you know, if you have sustained cortisol, you're going to have some difficulties later on. And he said, oh yeah, I forgot to tell you that they removed my spleen after a bullying accident when I was 14. He's now 51. How can you forget to tell me that your spleen was removed? Well, I didn't really think about it. And if people forget about which organ was removed, which they sometimes do, they also forget about which medicines they're taking. And do you have a checklist that you give to a patient that says, please write down for me before you come in all the medicines you are taking, and all the herbal preparations that you're taking, and all the naturopathic preparations that you're taking, and all the homeopathic preparations. You can write in brackets underneath, what did you buy at Dischem, Clicks, or Wellness Warehouse? And suddenly they say, oh yeah, I also have A, B, C, D, and E. Then if you look at those and you compare them, there's often a significant amount of interactivity that is and can be sometimes metabolically and physiologically relevant. So again, this is a reflection for you, but it's worth thinking about. Then we go through and we talk about, this is still in that bucket of how to manage the highest risk factors. We look at high risk situations, and 3 things cause a high risk situation. The first of them are your medication factors. High risk medications with a low therapeutic index that can be tolerated, but you need higher dosages. So you've got your medication issues, which also include then the polypharmacy that we've been speaking about, and the use of adjunctive issues. And then we've got your provider and patient factors. Overprescribing, underprescribing, and overprescribing is not only you overprescribing, but overprescription for the patient, because they like to shop around and see different people for different things. I heard recently a person, and they actually said to me, I'm going to see so-and-so because I know they will script me for this, but I'm not going to ask them for that because they won't. So I actually have a second practitioner who I see for my anti-anxiety meds, from the one who gives me my meds for my sinuses, for the one who gives me my antibiotics. And I said, well, why don't you see one person? And they said, well, the practitioner I really like for X won't script Y for me. So I go somewhere else. I don't tell them. And then you're getting into these factors. And then the third one are your systems factors, our work environment. Now, nowadays, if we spoke about this a year ago, telehealth necessarily wouldn't have been top of the list. But now if you're seeing patients remotely and you have a telehealth practice or a remote health practice, that plays a big role. The load that you're seeing plays a role. If you're working in the OPD, your outpatient department plays a role, the hospital factors play a role, COVID has played a role, and the high-risk situations of medication and people's behaviors play a role. Now, those of you that have been, just for yourself, think about this. You often see patients who you send to the hospital pharmacy to get their meds pre-discharge. How many of you have been in the hospital as a patient and gone to get your meds post-discharge? You get a packet full of meds that you don't necessarily understand. You might still be slightly sedated or groggy. You might be in a rush to leave. Now, the systems factor of the medicines that you've got with your ability to recall what you needed to do with that medicine is sometimes different. I remember having a conversation with a patient who brought in a bag of Clexane injections. And they said, yeah, you know, I knew I needed to take these, but I couldn't really remember when or why. And you think like, holy cow, did you just say that out loud to me? Did I just hear you say you weren't really sure how to administer your Clexane when you're at home post the operation? And they say, yeah, you know, was I supposed to put it in my thigh? Was I supposed to take it in the morning? And then you say, well, who sat with you and said, this bag of injectables is for this, these meds are for this, these ones are like this. Here's your Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday pill boxes. And this is how you put them into them so that you don't contaminate. So these are the basics, which for us seem obvious. I'm sitting here talking to you, and I'm sure there's a lot of you going, come on, seriously? Is this what we have to think about? But actually we do. We need to take the very basics of what we would need our parents to know or our children to know and apply them to our patients when it comes to managing high-risk situations. Now, I've put this up because one of the risks that we have in a high-risk situation is the use of investigative and off-label use of medicines. Now, this comes out of the WHO statements of late last year, that it can be ethically appropriate to offer patients experimental or off-label interventions on an emergency basis outside of clinical trials. I've put this in because this is very much a place that we're living and working in right now. But there are certain provisions, provided that no proven effective treatment exists, provided that it's not possible to initiate clinical studies immediately, provided that the patient and or his legal representative is given informed consent. And I wanted to just pause on this point for a minute, because informed consent for the prescribing and use and recommendation of medicines that may or may not cause an adverse effect is really important. And not only for COVID-related infections, but in all your care, do you have a medications consent form where you're explaining to the patient that these medicines may have side effects, and these side effects may create drowsiness, thirstiness, irritability, skin rash, anaphylaxis, drug interactivity with other drugs. They may reduce the efficacy of other treatments, so that the patient understands and notes that they understand. And then the emergency use we know about. Then the final one goes back to some of the comments we were having earlier. The results are documented and shared in a timely manner with a wider medical and scientific community. Now, in our case, if you have a medication admissions chart or form, one of the questions that you would be able to answer is, how many patients have you prescribed this medicine to? And what were their responses to those medicines? So a question for you, just as we pause, how many of you ever used the anti-inflammatory medicine Vioxx? I was talking to a very capable executive the other day who was part of the Vioxx rollout back in the 1990s. Some of you will remember the 1990s. It was the day before Google was really as effective as it is now. And Vioxx was a very popular anti-inflammatory to be prescribed. The problem with Vioxx is it caused significant cardiovascular and cerebrovascular risk. And ultimately it was pulled off the market. But the reason that I raise this, and the reason that I think it's relevant in this case, is because we often found to have significant social pressure to give an opinion on a preparation or to give an opinion on a medicine. And if you are asked to do that, what is your opinion? Are you making a personal opinion? Myself as Brad informally thinks the following, versus myself as Dr. Byra has a clinical opinion of the following, versus it's my recommendation that you should take or use the following. They're three quite different things. And it's very difficult as a registered practitioner with Health Professions Council, seeing patients in a professional capacity, to have your comments of your personal bias separated from your professional and ethical conduct. So bear in mind with medication, the recommendations that you do or don't or will or won't make in these circumstances hold a greater bearing than they did 6 months ago. I don't know about any of you, and just think about it. And I'd actually be interested if any of you posted up or made a comment. How many of you have had a patient ask you about ivermectin in the last 6 weeks? Obviously, I would say to you, put up your hand and show of hands, but I can't see hands either. But I would be surprised, out of the 30 odd people on today's call, that every one of you hasn't been asked at least this week. And we know that there's at least 5 tablet preparations that you can buy. And we know that of those 5, every one of them has therapeutically active pharmacological products that are not ivermectin. Some of them are diclofenac or diclofenac, as I called it. Some of them have got corticosteroid in them. Some of them have a whole lot of other therapeutic preparations in them. So if you're starting to be asked about these things, recognize that part of medication errors is an opinion that you give on the efficacy, validity, and reliability of a preparation, because it does play a big role. So we spoke about high-risk situations, and the reason that I put the use of off-label medications in high-risk situations is because I am of the belief that the use of a medicine outside of its formulary, not only its national formulary, but also the formulary of your hospital, because the hospital you work in has a formulary. So, and I say that just to pause for a moment on a high risk. One of the most interesting pieces of work I did, which was in the early 2000s, was working on single exit pricing and the movement from one induction agent to another. And we rolled that out across nearly 100 hospitals across 18 months. And as they moved from the originator, which you knew was as the ethical drug, to the multi-source, what you knew as the generic drug, took a significant amount of education as to dosage changes, adverse outcome changes, efficacy, half-life of the pharmaceutical agent. So a lot of that happens, and it puts us into high-risk situations. And sometimes those are caused by the pandemic. Sometimes they're caused by changes in a country policy, but sometimes they're caused by changes in funder or third-party payer policy, where the third party says, we're only going to pay for the generic. We're not going to pay for the originator medicine. Otherwise, there's a copay. And suddenly, your therapeutic desire to prescribe a specific preparation is challenged by the funder's regulation of what you can and can't prescribe under care. So recognize, and I'm not saying what to do about it, but I am saying recognize that some of your best therapeutic intentions may be hamstrung by the payment plans that you've agreed with the third-party funders. And it's a challenge. So I'm just raising that out for you. Then I'm saying transitions of care are a second thing that creates the risk of a medication error. And because patients move from out of primary care into secondary care, into hospitalization, out of hospitalization, they often have a significant amount of people caring for them at different points in time. So being able to, at the very least, have a formal structure to reconcile medication at different transition points in care is important. So do you have a best possible medication history? And part of that is by interviewing the patient, and part of it is by interviewing other sources. But part of it is saying, do you have a medication list, and is that medication list updated? And part of that is you might want to give that to a patient and say, here's my list. Please fill in on this list all the medications you're taking, how many pills you're taking, what doses, and preferably take a picture of the box with the label on it and send it to me. That way you can reconcile and update your medication list. If you have a patient that you've seen and they're on an extended period of care, have you explicitly said to them, this is the communication piece, please let me know when you finish your medicine. Please let me know when you've changed your medicine. Please let me know if you've added medicines to this so that you can update your file. Because otherwise what may happen is you may see the patient come back. And remember, we're not talking about 95 out of 100 patients. We're talking about the 5 out of 100 patients who aren't behaving in a way that was predictable. So having your best possible medication history, having a medication list, and having a communication strategy with patients about their changes in medicine helps manage transitions of care. And we're finding as patients go into and out of a hospital and into and out of your and other people's care, we find that that's becoming increasingly important. So I thought we'd just change gears slightly and start looking at medication management. There are 3 steps in terms of safer prescribing that you want to know about. HPCSA booklets touch on this, booklets 4, 5, and 9. So your record keeping, your disclosure specifically are important, as well as your informed consent. Have you developed and documented a clear rationale for why you want to use a medication or combination of medications, given the risks that the patient presents with? So there was a case in the UK that affects us called the Bolam case, which was then followed up by a second case called the Montgomery case. And those of you that like to read these, you're welcome to. In the Montgomery case, which happened very recently, the courts ruled that you need to tell the patient what they reasonably should know and expect to know. And that would include what medications they should be taking and why you're choosing medication A over medication B, given the risks of side effects, or given the metabolic risks, and given the outcome that you're expecting to see. You need to have this conversation with the patient to say that these are my, as the clinician's recommendations, recognizing that it's the patient's choice what treatment they accept. And this takes me back to a conversation that I had with you early in this presentation to go back and look at booklet 3, Ethical Guideline 3, so that you can understand and see what the patient charter says. Because the patient charter says it's the patient's responsibility. However, the patient forgets that. You make a recommendation, they disregard your recommendation, and when they have an adverse outcome, they come back to you and they say, you're a bad practitioner because you didn't make me do this. You've got to recognize you can't make somebody do something. And it's usually that breakdown in the transition of care and communication that causes so much stress. And then the last thing is to monitor the patient carefully. Are you monitoring the patient closely enough to see where the problematic side effects are occurring? How do you know? If you've put somebody on a patient on a medication regime, how are you following up with them 24, 48, or 72 hours later to see that the side effects are not problematic? And we're going through this vaccination journey now. And one of the things you say is, well, you may feel a little tired, you could have a little fatigue, you may have a slight fever. But the challenges of the global vaccination rollout and the no consequence deferment of liability that the pharmaceutical companies are asking for is they're saying, we don't know how many side effects there'll be. We haven't had enough time to test it. So now, where do we sit? You treat a patient, you give them some medicines. If you're not following them up, you could, under our current circumstances, be considered not to be thorough enough in following up. So WHO talks about 5 moments of medication safety. At this point, you could flip back and say, do I remember the 5 rights of medication risk? Right patient, right dose, right time, right route. And so you can think about that and see. Here we go into 5 things. When you're starting a medication, what do you need to be aware of and what do you need to educate the patient on? When the patient takes their medicine, what should they be aware of? Should they take it with or without food? Should they take it first thing in the morning? What happens if they get it mixed up? What happens if they've dropped them down and they pick them all up and the morning meds now become the night meds and the night meds become the morning meds? What happens when you add a medication or subtract a medication? How often are you reviewing medication? And what happens when they stop medication? So between yourself and the pharmacist, you need to bear in mind that these are the recommendations that the WHO has made for a patient. What do I need to know when I start my meds? What do I need to know in taking my meds, adding a med, reviewing my meds, and stopping my meds? That's the same as what you need to be educating the patient on, communicating to them and recording not only in your consent, but your patient notes. And that may be a standard patient education leaflet. It could be that you make a specific note that refers them to their package insert, but you need to have some kind of clear guideline as to where you want to go with it. So drugfreect.org is an interesting organization. And one of the things they do is they've made a reference to 3 strategies for safe medication management. The first is safe use. Why am I being prescribed this medication? How much do I take and for how long? How will this interact with my other medicines? What are the side effects and what are my options for managing my pain? These education programs for patients are the same things we can learn from into what we need to do to educate our patients. So, question for you, self-reflection, is when you prescribe to a patient, how many of these 5 questions are you asking? And how many of these are you answering on behalf of the patient in terms of the 5 medication moments? With that, then, 2 of the biggest risks is medication storage, keeping medicine in its original packaging, not saving leftover medication and locking medication away, and then how to dispose of medication. Often with the patient, you give them the meds and say, take these till the course is finished. But what happens if they don't? What do they do with that leftover medicine? So these are small things, but it's often the small things like a small stone in our shoe on a long hike that makes us aware. A legal colleague of mine, a chap by the name of Mike Juden, sent this to me, the picture on the left-hand side, which I thought was particularly relevant, especially because I used to use the alphabet that you see on the right-hand side. And I still joke, I see script sometimes when we do discovery, and what discovery means in this instance is your patient hires an attorney, your attorney decides that the patient has a case, and they write to you and they say, dear doctor, please give me all your notes as it relates to patient Brad. And I get those notes and it looks a lot like what you see on the screen. I scratch my head and then I look at my glasses and I have to turn it around the other side, and then I hold it to the side, because you just don't know what people are writing half the time. How often do you go back and you look at your own notes and you're like, oh, what actually does that word mean? So I love this, and I thought it's particularly relevant when we script. I think when we script, we write badly because it almost looks like a line on a page that we've done on a train, but we can't really say what the wording means. So eligible, legible scripting, eligible, legible records is really, really important. And it's as important in your informed consent and disclosure as it is in your legibility of prescriptions. So this is the fundamental rules when it comes to issuing prescriptions. They're not my rules. They're the HPCSA Booklet 9 rules, section 7 specifically, that you have typewritten rules for the lower schedules and handwritten prescriptions for the higher schedules. So I know you're following this and this is academic for you, but it would be inappropriate for me not to talk about this. So it's appropriate for me to say, go back and look at how you are issuing your scripts. Firstly, are they legible? Especially, and interestingly enough, the highest schedules where you need handwritten prescription is where you've got the biggest risk of illegibility. So in terms of patient records, we speak about this often. You need to have in your record, and we spoke about this earlier, the proposed clinical management, the medicine and dosage, their reactions to treatment and adverse outcomes are there for you. You're required to record that. If you're not communicating with the patient, how are you effectively and accurately recording that information? And then, of course, test results and any blood work. So one or two more comments as we wrap up, because we're going to wrap up in 2 or 3 minutes, ask for questions. The first comment to you, and I say this with the deepest respect, because 9 out of 10 complaints that I read are frivolous. Every now and then somebody has not paid as much attention, and sadly, it results in an outcome that was preventable. But sometimes they are not preventable, and sometimes they are known complications. But in terms of medication, document everything. The proper medication labeling. Make sure that there's legible documents. Make sure that you've got a record keeping of your administered medicines. This is the one, when we start talking about a medical error or medical misadventure, your lack of recording of your administration plays a big role. Checking the prescription label and expiration date against the medicine and educating your patient the same way, and making sure where you're bedside with the patient or wardside with the patient that the correct medicine has the correct label, because you can have the correct medicine with the incorrect label, and that can get you into a lot of difficulty. So 10 strategies as we wrap this up. The first is ensure the 5 rights that we've gone through. Follow your medication reconciliation process, and if you don't have one, set one up, and then double and triple check it. Think about checklist manifesto and Atul Gawande. If you are working in a ward and you're busy, have somebody else read it back to you. Consider what your naming alerts look like. If you're doing 0.25 or 0.1, put a 0 in front, because sometimes a 0.1 becomes a 1, and then suddenly you've overdosed the patient by a significant amount. Document everything, and then manage proper storage. Learn your hospital's administration policies, regulations, and guidelines. Even if you're not administering, know what the guidelines are. And then make sure that you've got a drug guide. How many of you remember, and I'm going to call it the old days, we called it the 90s. Remember the 90s? You had a MIMS manual with your Merck manual. Now you've got a handset, and you've got MIMS on handset. So make sure that you've got something so that when a patient does talk about a preparation that you're not sure of, you can desk reference it or handset reference it. So this is my universe as we close out today. The first is be aware that in the medication risk model, you will have early priority actions. Know what your high risk situations are, know about polypharmacy, and be aware of where transitions of care with your patient are with other healthcare professionals. Know who your high risk situation people are, your inpatients, young patients, and the elderly. Be aware that administration of the wrong dose and the rights is important. Be aware of polypharmacy. Know that 4 or 5 medicines plus over-the-counter preparations give you a significant increased risk of side effects, a significant increased risk of drug interactions, and they create complications of adherence and compliance. Know also that transitions of care play a massive role as patients move between facilities and their home, and that the more transitions there are, the higher the risk of communication errors. So consider your prescribing, transcribing, dispensing, and administering. Consider where things are weak. You could have strong medication systems, but lots of human error. You could be tired. I don't know about you, but mentally it's been a very hard 18 months for me. I think I'm as sharp as I used to be, but probably I'm not. Be aware of adverse drug reactions. Assess your 5 moments that we spoke about, the 5 moments of healthcare from starting to ending medicine. Try and empower your patients and encourage adherence as much as possible, and understand that we need those 4 components. We need the patients to work with us as healthcare professionals in terms of the medicines off the back of a good, solid system and practice. So this is my landscape view for you. We're at an hour now, so I want to say thank you very much for having me back. Metaphorically, I bought my own coffee and my own biscuits. I always said I like these CME talks because I got coffee and biscuits. So cheers to everyone. I'm going to hand back to yourselves. If you've got any questions, please send them through.
Thank you very much, Dr. Byra, for their really great presentation. Any questions from anybody? While waiting for that, I would like to remind you that the certificates will be issued by the sponsors. If there's any problem, let us know. Open to questions. Any burning questions?
Thank you, Dr. Byra. That was most informative. Much appreciated. Thank you for your time.
Thank you, Brian. Absolute pleasure.
Anybody there? I think, Dr. Byra, you've covered it so well. They don't have any questions whatsoever.
Well, we know
Thank
that
you.
the best questions happen afterwards. It's like when you're driving on the road and someone cuts in front of you, and then your best insult is only an hour later. So if you have any questions later on, please let us know through yourselves, and I'll share information.
And thank you very much, Dr. Byra, for an excellent presentation. And thank you for allowing us to host the event at Bedford View Gardens. Really appreciate it. I'll be preparing a nice mail to each of the professionals, and I'll be sending out their CPD certificates. Thank you very much.
Thank you, Jeanette.
I see there's a question from Dr. Jardine.
Thanks, Janine.
Thanks for the most informative presentation. And the question is, could we have a recording of the presentation? Dr. Byra, that was, you see, we are recording everything with permission, but we'll discuss further with Dr. Byra whether we can make this available to our doctors. So we'll come back to you after discussing that with Dr. Byra. I see charts. There's a question.
Okay.
Can we get contact details from Dr. Jardine? Contact details, what do you mean, Ivan? Contact details for Mrs. De Villiers, Dr. Byra, myself, what do you mean, Dr. Jardine?
I think it will probably be on the email that Jeanette will send out.
Okay.
You'll
I'll have all the details on the email.
contact her.
All the details will be enclosed, so not to worry. And Janine's also got all my details.
Perfect. Thank you.
Okay, thank you very much, everybody. It was really
Thank you, Doctor. Much appreciated. Thank you, Brad. Thank you, Michael.
Thank you.
Enjoy the rest
Thanks,
of your week.
everyone. Have a great day, Brad. Thanks for an informative presentation.
Thank you
Thanks,
all.
everyone.
Thank
Be
you.
well.
Bye. Bye.
Bye.
Thank you. Bye.
Have a good and safe day, all of you.
And Jeanette,
Thank you.
the register a bit later on today. Thank you for your help.
Thank you. Keep well. Bye.